Thank you to the MassTLC for inviting me to be here, and to all of you for listening. Thanks, Christopher and Daniela, too, for two fantastic presentations earlier. I'm going to try to follow their acts here, and I'm going to change the topic a little bit. We're going to focus on healthcare and think specifically about the patients of the future, hopefully of the near future. Tom mentioned that I come to you today from the ambulatory practice of the future, which is actually in operation now, not in the future, but it's I am an internist, a general practitioner in doing general medicine at Mass General Hospital, where this practice lives. And just sort of give you a little background on that and the platform from which I come. It is a primary care practice that takes care of the employees and their adult dependents at our hospital who are insured by the hospital. We'll talk a bit about why that may be important, but that gives us some control over what types of innovative services we may want to pay for. And thus, it is sort of, to us, a living clinical innovation lab, something I've worked on developing, designing for many years with Simit's help, and we were able to open a few years ago. My background is also in biomedical engineering and public health studies before I jumped into the world of medicine. So just to give you a little bit about me. So let's get going, because I know Tom will keep me on time today. Just to start you off with a little humor, but this says a lot about where we've been in healthcare. All of you have stood where this poor gentleman's standing, wondering, really, does it have to be this way? This says a lot about our culture, too, so we'll talk a little bit about that up front. So what I'd like to do first is walk you through a few ideas around trends that are already happening, things that are changing now that make this something of the past very soon. Let's look at those, and that will inform what I'm going to tell you today about the patient of the future. So that's where we'll end up. So you've heard these terms, you've heard some of these things. Let me give you my take on trends from the healthcare system side. So the Accountable Care Organization, the ACO, the general idea that you will integrate care across a group of providers who take care of a population of patients, right, who will be reimbursed for showing that they can improve the quality of the care that is provided and even affect the overall cost of care over time. We're still trying to figure out what the heck that is, but those are the right goals, I think, and they are an important, they push us in an important direction in terms of what patients will experience. Accountability, though, is an important word, and we'll be thinking about that as I go forward. These organizations, though, will, and these types of contracts are already happening, payment for value. So getting away from the fee-for-service office visit, we call it the hamster wheel, that I've lived a lot of my clinical life on, where we pay for volume, which we all now know really doesn't necessarily equal quality, and especially in the world I work in primary care. And what this enables, has enabled us to do at the APF, as we call it, is to be freed up from that fee-for-service revenue driver and think more about how we can be paid globally and therefore be very innovative in the services we provide, as long as we are reaching our business goals ultimately of improving the health of the population generally and creating a better experience of care for them. All of this signals and causes, to some degree, a culture change that needs to take place. Suddenly, it really is very important. To some of us, it always has been, but it's very important to make sure we are engaging patients. Part of this accountability is, I'm taking care of a population of patients, but are they somehow accountable to what I'm trying to do for them or for themselves? And many patients intuitively want to be accountable to their own care, but we need to think about creating experiences of care that are consistently excellent for them, because that's part of how we will engage them, how we'll keep them coming back and interacting with us. We are looking for their feedback and being measured on that. In fact, now some of the contracts we'll work under will tie some of the dollars we could bring into the organization to how we're doing in the patient's eyes. We're inviting them into these patient and family advisory committees or councils that now are appearing pretty regularly across organizations and in practices, where we get direct feedback from our own patients about how we're doing. So that's an important trend to keep in mind. We have data, in our literature, we know that an educated patient, an informed patient will have better outcomes. So I'm not going to dive into that right now, but I'll ask you to accept that that's true, and we have many examples of that. And so again, helps us think about our new sort of business paradigm. Well, we've got to engage these folks and help them become more accountable to their own care and more educated. Technology. So a lot of you here have thought about potentially technologies that could influence the care of patients. And there will be, and there is now an increasing demand for technologies that will enable us to accomplish these sort of new goals of thinking about populations and segmenting those populations and understanding how to be proactive in helping them manage illness. I want to quickly show you a slide that's a few years old. It comes from my colleague Ron Neubauer at CIMMYT, to make the point that we have believed for a while that technologies that allow diagnostic and therapeutic interventions that traditionally we assume have to happen in the highest acuity, most expensive settings, will march down this, what Ron calls acuity curve, to less intensive and less expensive settings out into perhaps the practice I'm working in, into the community and ultimately into the home, or I would say wherever the patient may be. So a lot of you are thinking about how, what that may look like, or there are tools out there already. We haven't engaged those tools or technologies as well as we could have to this point, and that's in large part because of the way the fee-for-service healthcare system has worked, but I see that changing now. All right, let's look briefly from the viewpoint of the patient. What's happening, the patients are seeing. Well, here in Massachusetts, there are a lot more insured patients than there used to be. What I didn't put on this slide, but which is equally as important, is that there are still not enough providers. There are not enough primary care providers. I was talking to someone about that today. And so that has implications for what patients may be doing, which we'll talk about in a moment. It also has implications for the fact that we need a greater workforce in primary care. Patients will be exposed more to the cost of care, perhaps in the co-pays that they pay, and as employers in particular try to shift a little bit more of the cost to the patient. So the patient's asking themselves, what is the value of the service I'm getting? An increased customer service expectation, not just in healthcare, but in general, I think, in our society. Fortunately, I think also there's a growing societal movement towards improving our health, and that's probably gone up and down throughout the history of mankind, but it feels like we're on a little wave right now where you can't turn around without hearing Dr. Oz telling you something you ought to be doing. And I think right now, I'd say my patients are listening. They're bringing that information to us more and more and saying, how do I sift through this and how do I get healthier? We've talked about today the importance of access to information and what the web enables us to do, and that you can do it in a mobile way. And that sort of insatiable appetite for that extends now to healthcare, and patients want to have that kind of access to information to own and manage and inform their health. Patients hear us saying, and this is part of that culture change, we do want your input. In fact, it seems that if we can incorporate your preferences into the type of care you may want, it may focus around a specific procedure that's coming up or options for managing a specific problem. It seems that there's really good data to show that will lead to a better outcome. That will improve your health in the right way, in a customized and preference-sensitive way. So that's important. And so, again, it's also telling patients our culture is changing. We're asking for your input. Patients, when they haven't gotten the answers they want from us, turn to each other often. So they do that sometimes face-to-face in group settings that we are seeing more and more happening in our midst, but also they're doing it online. And that's not new. That's been going on for a while. Patients, there's some remarkable examples of patients helping each other to solve problems in managing chronic illnesses that they may share in ways that I could never help them to do. I've not experienced what it's like to live with multiple sclerosis, for instance, and there's a site where patients log on together at a certain time and teach each other how to give their interferon injection, what side effects they might feel. So these types of things are happening. They're remarkable examples of how patients are taking control. So let's think about that for a moment, the patient taking control. We've talked for years about the importance of self-management, and mainly we've been thinking about let's educate our patients as best they can, but it's still a very paternalistic model that we've worked in. That's changing. This slide is actually a few years old, 2005, from the California Health Foundation. It's a nice, simple sort of look at where this idea of self-management may be going, and the idea that across this grid there'll be different types of technologies of varying from low-tech to high-tech that will enable patients to do more and more for themselves. Again, we've mostly lived traditionally here, where we're very directive to patients, telling them what they should do and then expecting them to go off and do that, but without very much support between interactions. moving more towards a collaborative model now. And that is something we're doing in our practice right now, where we are not just educating patients, but we have in our practice a coach. So this gets to the importance of the behavior change piece, the tough stuff, that really, what does it mean to take in information, to be educated, and then actually learn how to use it, and then have a partnership to support you as you move along. So a lot of what we do is low tech still, patient education materials that we hand them or give them online. But we are preparing now to move in this direction, I think, more and more, and that's where I want to focus today. The question is, what's out there? If we allow patients, if we believe that patients should become more autonomous in their care, that's a good thing, that the smarter they are about managing their health, the healthier they will be, and that will be better in many ways for our population, not just for the accountable care organization, for which that's sort of a business goal now, but for our society, our economy. Then what does it take to get out there, and what are some of these advanced technologies that perhaps we're going to be seeing? What does this patient of the future look like? This is Neo from the Matrix. Is he all-knowing, all-powerful, absorbing all that information and data, and does he need the doctor? Well, let's talk about that for a few minutes. So beyond that graph I just showed you, where are we going? I think one potential viewpoint of where we're going that I want to propose to you today is that advanced approaches to health education will enable patients to achieve mastery. Maybe that's something a little stronger than autonomy, but mastery in managing their health and become drivers of care innovation. Say something that might sound a little controversial to some of my colleagues, and now I'm being recorded, Tom, so they're going to hear this. By 2020, expert patients will manage 95% of their preventive care and chronic disease management, largely independent of traditional healthcare encounters. These things are already happening, so I'm pushing the bar a little bit here. I didn't say all care, and I didn't say all patients, but that's something we can talk a bit about. So that's my sort of controversial or provocative statement that I wanted to make, and now I'm going to tell you about why I think that really could be. All right, let's focus on Frank. I don't think you know Frank. This is Frank's stock photo, so you probably don't know him, but it's 2020, and Frank is 60 years old. He has depression, diabetes, hypertension. You probably know somebody like Frank, and these are common illnesses and common issues that we talk to patients about and try to help them with managing. So you can see him sort of pondering, where are we going? What's it going to look like? Let me show you another picture of Frank where he looks a little more hopeful. So what's going on around Frank that enables him to achieve what I just said, that he can actually become more of a master of his own health? Has he freed himself up completely from me? Has he left the healthcare system behind? No, I don't think that's going to happen. There's a primary care team, and you may have heard the term patient-centered medical home. That really is a term that's supposed to describe all the service and support that you would need in sort of a medical home base, a place where you go to get all your needs, potentially. That's depicted here, and there's a team that looks like some pretty traditional folks, probably doctors and nurses. But what you could envision here now is that there's new types of roles and skills that are present. I mentioned health coaching. We're doing that in our own practice. And I think now the teaching piece, the education piece, that type of expertise is going to begin to live amongst this team. And when Frank comes and meets his new team and has an initial sort of assessment, then part of what's going to happen is here that Frank's going to go back to school. And I think what I envision is that this education and coaching piece continues to evolve, and that this is an opportunity for all of us to think about how, in fact, the science of education could be applied inside of healthcare. And what will it mean for Frank to engage in this kind of activity? Well, around the hypertension, the diabetes, and the depression, it may look to some degree like sort of traditional education interactions or opportunities where patients come together. Again, this isn't a crazy idea. They're doing it now. But maybe it's more of in a classroom type setting, or it's inside the practice where They initially begin to absorb some information that's being imparted upon them, as we do now. But then we go a little further. We begin to test them. How well did they absorb that information? And we try to apply the sciences of personality sort of analysis. How does this, and sort of cognitive behavioral sciences to understand how does each patient, in their own way, absorb information? How do they like to receive information? How will they do best in receiving that information? The things that we think about for young folks who are going to schools and sometimes struggling. How do we impart information in an effective way and begin to help them truly learn and then reflect that learning back to us? So you can envision we'll be testing Frank on that knowledge. But it goes out beyond the classroom now to move in the direction I'm suggesting. Of course, it's putting Frank into his world and living his life and using that information, and now testing, does he really not just understand what we taught him, but can he use it? So the classic example, of course, is, and many of you know patients with diabetes, they truly are the expert in their care because they not only learn what the pathophysiology of the disease is, they understand very well, if they've been managing diabetes for a while, how their behavior affects their blood sugar. And we've gone that next step. We've handed them a lethal drug, insulin, and we've said, you know what, you can manage that too. Here's how you titrate it. Here's how you dose it, depending on what your blood sugar looks like. And so they're out there sort of, they've taken that next step. And I'm proposing we're going to expand that idea across many different medical conditions, chronic illnesses. So we're preparing now in our practice to launch a pilot where patients with high blood pressure, like Frank, will also titrate their medication. So we're taking that next step and giving some of that authority over to the patient. This picture, of course, depicts that Frank is mobile. He's out there living his life. But it also suggests something that is happening now as well, is that Frank will be peering into his records. He's doing that now in our practice. He can see my notes about him. He can see the shared sort of care plan that we created together. But he can see data. He can see information. He's going to need software applications that allow him to be able to interpret that more readily. Not just wait for me to tell him what it means, be able to take that massive data and use it effectively. He's going to be given more power, and again, we're on the verge of this, but not quite there, to actually act on making decisions when there are very good algorithms around what needs to be done. You're a certain age, you're a certain gender, there are certain screening tests that have to happen. I'm a barrier to that, traditionally. So take me out of that equation. Not entirely, because I want to make sure that something's happening. I can still monitor how Frank's doing, but the colonoscopy gets done, the mammogram gets taken care of. We're putting that power into the patient's hands to make sure those things get scheduled and ordered and done. Other types of routine screening tests. Now, some of the barrier, too, is, again, going back up that acuity curve, is that Frank has to go places to get things done. So how will technology sort of move out into the community and into Frank's home? So this is just to represent that technology. There's going to be sensors, of course, is part of it. There's going to be collection of data. And again, a lot of these tools and technologies have been developed. But now, I think because of the way I've sort of suggested to you the trends that are happening and the world we're entering into, it's finally time to begin to implement them, and there'll be a business model in a way to make that to create viable businesses around that, so that the accountable care organization and the patient to some degree are ready for these things more than ever. So there'll be sensors that tell Frank how his blood pressure and blood sugar are doing, perhaps even beyond that, sophisticated ways of Frank being able to measure how is my emotional and cognitive health, and understanding how to respond to that. So where those sensors live, are they perceptive to Frank, or are they things he has to go and grab, put on a blood pressure cuff? That's where exciting developments are happening. I'm not focusing on that today, but I'm suggesting to you that now is the time to begin putting them in place, and by 2020, they will be a crucial part of how a patient like Frank really manages what's going on around him. So again, that data is a very tight feedback loop to Frank. He's responding to it. He's managing his behavior. He's learned how to even titrate medication. There may be other techniques and approaches he's learning about managing his health. But I think all of this is possible because of those trends and because of where Frank will be in 2020. I expect that this will lead to sort of levels of mastery. You know, as Frank sort of demonstrates his ability to manage these things and to improve his own health, we will learn how to sort of measure those different levels of mastery, perhaps, and use that information as we, the care team, respond to what he may or may not need. So we're going to be thinking about, well, how is Frank doing? Has he achieved some level of sort of certification in this process? And how does that influence when we need to interact with him? Should we interact with him? Continued guidance he may need. We are looking right now at a project that will begin soon with the MIT Media Lab using a platform, a software platform, that essentially walks a patient through an education process. And the term that we've been using is apprenticeship, which is an interesting word. It really is about showing patients how to do these things, and then they begin to do them, being there, sort of holding their hand through it. And the software in particular uses new ways of depicting information and data that I look at all the time, but that patients would maybe struggle with, but simplifying that, creating images that make it clear how the behavior and the medication or whatever the intervention is affects their own physiology, their own health. And so I'm excited about that. I think we are now at the point of beginning this idea that apprenticeship creates these more mastery around managing your health, and that will move forward and we'll be able to measure that. I did say that the patient's care team has not disappeared, and so there needs to be some ability to mine the data about our populations and about individually, in this case, about how Frank is doing, so that if things fall outside of what we might expect, jump outside of the range that we've anticipated Frank should be in, that we can be there to sort of understand what's going on. We can, as Christopher, I'm sure, would say, predict even before that, look for changes and signals that help us get ahead of a complication of a chronic illness that could be developing, prevent unnecessary care episodes. So the care team is still there, and I think, again, responding in different ways depending on what the patient may or may not need and what they can achieve on their own. And then there's something that's also very powerful that I see, again, happening now, but becomes even more important as these types of patients are able to develop this type of mastery. And I think that is that they're interacting with each other in even more powerful ways. And that's pictures to depict that there are groups of patients helping each other to solve problems together. And that I think it even is likely that expert patients, in a way, will be appearing inside of primary care teams, other types of medical teams, and working directly with them. That's not a new idea. There's a model called a promotora you may have heard of in Latino communities. I've seen an example in Santa Fe of a clinic that is run by the promotora, where the professional patient, in this case, who's learned how to manage their diabetes, knows what it means to manage their diabetes in that community, with in that culture, with the constraints sometimes that exist in looking for healthy foods and finding ways to exercise. In this particular practice, the patients come to see the promotora, and the average blood sugar, one of the ways we measure that in diabetics is something called the hemoglobin A1C. When I looked at this practice a few years ago, it was one of the best across the whole country. So, the importance of, again, the patient understanding things that we can't understand about what it's like to live with chronic illness will be more and more implemented into what we do. So that's really the vision I wanted to give you. I don't think it's so far out. 2020 might even be a little too far out. I think some of these things are happening now. I guess our challenge is to think about what are the tools that will enable this to happen, because I think on our side, the changes like the ACO and the culture change that goes along with it is happening now. We are at the APF very excited to be testing these ideas, helping our patients move down this continuum. And so I think the future looks very bright for patients like Frank. So I'm going to stop right there, and would love to take your questions or comments.
I'd like to ask you a question about how you're treating Frank, and I'll preface my question by saying that we know that people that have chronic medical conditions and behavioral health issues, in Frank's case, he's got diabetes, he's got hypertension, and
Right.
he has depression, cost about 3 times as much as people that just have chronic medical conditions. So the question about Frank and your treatment of Frank is what are you doing specifically about his depression, and how are you treating that?
That's right. That's a great question, and you're right. And we've found in our current practice, our major focus in someone like Frank is to address the depression first. You can't get to the other things until you really get an understanding of how to help him make some movement in that area. So I think in part it is that, it's partly on our part recognizing that, where it used to be the last thing we thought about as we ran out the door, right? So it comes first. It's making that point to the patient that that's a very important thing, and it's going to be a barrier to their health otherwise. And then it is, again, it's education. In our case right now, it's coaching. We are coaching our patients with depression, and we're teaching them techniques that have been around for a while called cognitive behavioral therapies, right? Learning how to respond to my own moods, to sort of frame shift, move something that seems negative to a positive. So some of it's, in this case, very much about the behavioral piece. Again, for many patients like Frank, there may be a pharmacotherapy piece. And so we expect on the heels of the upcoming pilot that we're going to be doing to think about in which patients would it be appropriate for them to increase the Prozac dose based on measurements they're doing, objective measurements, scales that have been standardized around how around how their depression's doing. We use blood pressure to make those decisions in hypertension. We have some scales we can use also for depression and other mental health illnesses. So I think that's the direction we're going, but it has to be an emphasis. The depression and the mental health piece has to be first, and so that's the approach we're taking there.
All right, while we're waiting for the mic, I have a quick question, or maybe a couple of questions. I think this is fascinating, and obviously the movement of consumer empowerment or customer empowerment is not just impacting your industry, but many of our industries. It leads me to think of two things. And one, with the amount of information available, and in often case conflicting or misinformation around healthcare, and the ability therefore for me or others to not only self-diagnose but self-medicate, how does that challenge this model? And then the second part would be, obviously, to enact a lot of this, you need a consumer that's quite educated.
Yeah.
And therefore, what percentage of the population do you think that this might be relevant versus, obviously, those that may be more challenged in implementing this?
Yeah, very good questions, important questions. So first part of your question is about all that information. And, I think part of the answer is that we've got to be able to help patients sift through that. We may be using tools that perhaps Christopher or Daniela are designing, to help us sift through information. We do that now in our current practice to sort of, here's our favorite websites, here's the applications we think have value. We want you to show us what you're using so we can help learn together. We're doing that with a lot of our patients now. But it's a morass of stuff out there. So I think if there's that sense of partnership, then the patient will be hopefully sharing that information with us. But I'm not sure how much we can control that right now or what it will take to do that in the near future, how to really sift through that information, make it usable. I'm sorry, the second part of your question? Yes. So, yeah, I've given you a vision that you could probably easily apply to many of us in this room, perhaps, but how applicable is it across all demographics? Well, I think, again, part of the answer to that is right up front, understanding the patient. What is their ability to absorb information? What is their culture within which they're operating? What are the constraints from a socioeconomic standpoint that they live under? I think we can apply these principles to any patient. How much they can do, how much technology they can use or can afford to use, that will vary. So I'd like to think these general ideas are widely applicable, but patients will need different approaches, different tools, depending on who they are. And there'll be different ways to engage them, and many won't get engaged. The interesting part of the work we've been doing is we are very proactive. Patients come to our practice, we set goals for their health right away, and then we have a lot of frequent follow-up with them. Most are intuitively ready for that. They've been looking for a team to partner with and help them. Some back away from me. They're not ready for this big hug I'm giving them. And so that's another piece that we're going to need to learn. You know, what is it that engages patients? We handle that in part by letting the patient set the goal. So it's not for Frank necessarily what I want to hear him say, which is, I've got to manage my depression, diabetes, hypertension. It's, you know, doc, my marriage, it's falling apart. That's where I want to focus. So fine, we define it, they define it, and we follow in that direction. So I think it'll be, in part, the answers are there.
So I'll just speak real loud.
Okay.
Anyway, I like a lot of the things you're doing.
Oh, he wants, got to have a microphone. Okay.
So I like a lot of the things you're doing. However, usually the impediment to wide adoption is it's not reimbursable.
Mm-hmm.
So what's your plan as you figure these things out on getting them out into other areas so they can adopt them?
Good question, and a tough one. So again, we're working in this self-insured environment where we can have some control over testing new services, new technologies, and trying to understand the value of them. So I think places like our current practice are going to have to be testing and proving the value. What's the return on investment, so to speak, and there'll be many of those types of returns. And then trying to prove to those who do pay for care, and that's mostly the payers, whether it's commercial, government, or in this case, large employers. But then what piece of it would patients, you know, perhaps pay for, especially as they are looking for more and more tools to manage their health outside of the traditional health encounters. I don't have the answer yet about how this evolves, but I think the ACO enables it. I really do. And so we'll be looking as our larger organization, Partners Healthcare, already is looking more towards investing in these types of technologies and having a sort of general idea of how we're going to do that as an organization. So strategizing around it, which is a good sign, I think. So,
could you just weigh in on how you have factored in considerations about liability along the lines of tort lawyer issues with the do-it-yourself patient,
right.
Taking into consideration the professional obligations that doctors have, and then do you foresee perhaps a future where that patient, that mastery patient or that self-empowered patient may in fact elect to exclude themselves from the HIPAA, the onerous HIPAA regulations that are not only currently in place, but the even more onerous ones that are in the pipeline that are going to come spilling out in the very near future.
So to take the latter part of your question, yeah, I do see that future, and you know, we talk to some of our patients about the idea that we're trying to learn not just what it means to take care of them, but this entire group of patients and how we might want to have patients even sharing information with each other more readily, to your second point. So I do see that we'll challenge HIPAA in ways that we didn't anticipate. To the first question, yeah, I've made some folks nervous, you know, my colleagues and some of the lawyers who work in our hospital, but I think an example of that is we are, you know, we are pushing towards new types of encounters virtually that may allow information to kind of get out there through Skyping with patients. And so we've had to ask patients for their consent to participate in some of these things before there's really a legal structure around that. Although in that example, I think we're moving towards a pretty firm legal structure. But you know, in terms of allowing patients to do more of their own care, again, I'm not suggesting here that we've stepped away from them or sent them out with tools that we're really responsible for without being able to connect with them and monitor them. I am suggesting we're moving down that path. We've got to have technology in place that allows us to know how Frank's really doing or alerts us when we need to act. And frankly, if we have that in place, it's better than we have now, right? You know, even if the rest of our system didn't change. So we're going to face some challenges, you know, and I think, though, as the work we do proves that this is better care, that those challenges won't be so great. So I know I'm not giving you the answer, but we'll have to face these issues. Right? Yeah.
A lot of your talk was about education of responsibility of the patients for chronic care.
Yeah.
If the education and responsibility model works, why not have it apply to preventative care so that patients avoid these illnesses in the first place? And a second question is, you mentioned about doctor shortages. Do you expect in the next 10 years a new medical school will be built in the United States, given there hasn't been a new medical school in probably decades?
Good question. So, yes, I think we can apply this to preventative care. I think we're going to, the goal will be to shift more and more of this type of activity across the entire population we care for. We've been very focused on the sickest of the sick, where the horse is sort of out of the barn. And now in the practice I'm operating now, we're very focused on folks who are 30s, 40s, 50s. There's risk, but we have a chance to sort of alter behavior and impart the knowledge and the skills that they need to begin to reduce that risk significantly, long before they're in trouble and before their parents, gone into trouble. So yes, I think we can make this approach apply to the preventive kind of care that needs to happen when you're young, and that'll have a big impact down the line. And I'm sorry, the other part of your question was it? Are we going to see more medical schools? Well, I think we will see some schools. Again, we were talking about that earlier, and hopefully with a focus on this kind of primary care training, because we are in some trouble there. I think part of our mission actually is to make this kind of career look rewarding, look interesting to students and residents who are sort of looking and saying, that it's hard to take care of folks in this kind of a setting, traditionally in primary care. There's sort of a grind to it. And a lot of what we've been doing at the APF is redesigning the operation and investing in more of those team members you saw up there to enable me to do what I'm trained to do and sort of parse out the tasks a little bit more. And again, the patient's very involved in that. So the more the patient can take on, the more that comes off my plate allows me to focus where complicated medical issues are happening that I should be focused on, that I was trained to do. So yeah, I do think that we need more folks in training to do what we're trying to do right now, and that we need to make this career as an option palatable and even rewarding and interesting to do. And so I see a shift towards finding ways to engage folks in going into primary care. And that may be in part how they're reimbursed to do it, because that's been an issue, but also just the enjoyment and the reason I went into it, which is that behind every door there's a different story, and the puzzle of sort of helping a patient sort out what's going on is the fun of being a general internist. And so if we can take the grind away, I think that more people are going to come into the field. So.
Great, thank you.
Okay.